Good morning, everyone. So, this is another session of Quest, and this is going to be very interesting, which is practically very useful for everyone. So, let's start with a prayer. So, I invite Thomas Achan.
Shall we pray? പിതാവിനും പുത്രനും പരിശുദ്ധഹായിക്കും സ്തുതി ആദ്യമേ നന്ദിയേക്കും തന്നെ ആമേൻ. മഹാപരിശുദ്ധനും നീതിമാനുമായ ഞങ്ങളുടെ സ്വർഗസ്പിതാവാം ദൈവമേ, 2025 ജൂൺ മാസത്തിൻ്റെ ആദ്യത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി. ഇമ്മ്യൂണൈസേഷൻ്റെ ഇമ്പോർട്ടൻസിനെ പറ്റി ഡോക്ടർ ജിൻസി ഞങ്ങളോട് സംസാരിക്കുവാനായിട്ട് പോകുന്നു. ഈ കാര്യങ്ങൾ മനസ്സിലാക്കുകയും മറ്റുള്ളവരോട് പറയുകയും അതിൻ്റെ ആവശ്യകതയനുസരിച്ച് ഞങ്ങളത് സ്വീകരിക്കുകയും ചെയ്യുവാൻ തക്കണം. ഇന്നത്തെ ഈ സെഷനെ ഞങ്ങളെ അനുഗ്രഹിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നു ചേർന്നിരിക്കുന്ന ഓരോരുത്തരെ അനുഗ്രഹിച്ചാട്ട് വരാൻ ആഗ്രഹിക്കുന്നവരും എത്രയും വേഗം കടന്നു വന്ന് ഒരുമിച്ച് ദൈവത്തിന് മഹത്വം കരയറ്റുവാൻ സഹായിച്ചാട്ടെ. പ്രാർത്ഥനയുടേതിനായി സ്തോത്രം. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. So, topic or the area for this Thursday's quest is very important. So, from the screen you can see why adult immunization is very important and vaccines are not just for children. So, Kerala is very special. So, what's special in Kerala? The population of the children is now coming down and aged population is increasing. Elderly population is increasing. Epidemiological transition is happening. So, we should be protecting our adults also. By default, we all think vaccines are for kids, and Kerala is very super for childhood vaccination, but we are not very super, or we are very lagging behind for adult vaccination. And I always look up to the medicine department who are very enthusiastic in adult vaccination, and very thank you, Dr. Jency, for taking up this challenge and for taking initiative for launching the program. And we'll start the session. And also we have the inauguration also.
Good morning to you all. At the outset, I would like to thank the administrators for giving me this opportunity to talk about adult immunization. So as Dr. Arun rightly pointed out, the pediatric immunization is such a well-structured, well-funded program across the world. There's so much clarity, but that's not the same with adult immunization. So as a department, we thought this is something which needs more emphasis, so we thought we'll look into it. And for today's talk, what I thought would be like to take you through a little bit about the background of immunization. Then we'll see why adults need vaccination. Now the list is exhausting, so we wouldn't be able to go through each of those vaccines, but I thought we would go through some of those vaccines in detail, and so also look at that subset of population with altered immunocompetence, because they need to be catered differently, and what should we know about that. So, does anyone recognize this gentleman in this picture? Very good. So this is Edward Jenner. So talking about Edward Jenner's story, so we have community medicine people and microbiologists identifying this scientist. So Edward Jenner in 1796, what he noticed was the milkmaids who were in regular contact with cattle, they were getting cowpox, but they were not getting smallpox. So this made him think there's something about it. So what he did was his gardener's son, James Phipps, he called him and he took the source from this source of the cowpox patient. Those are the milkmaids. And specifically, this milkmaid name was Sarah Nems. And he inoculated it under James Phipps' hands. And he did have cowpox, but he came out of it. It was an uneventful disease course of 1 week. He came out of it. 2 months later, he took the material from the source of smallpox patients and inoculated it under the skin of James Phipps. And as he expected, James Phipps didn't have smallpox. So that was the first event of vaccination. Strangely, when I asked my children, I was so excited about this story. And my daughter, who's doing management, she told me this story, and I was shocked that I didn't know about it, but they knew about it. And she did tell me what the name vaccination stands for. So it comes from the Latin word vaca, which means cow. So that's how the name vaccination came to be. So this is officially, and he published it in 1796. That was the first official documentation of vaccination. But if you look back around 200 BC, even Chinese doctors tried this, but it was with lots of mortality. So that was not a successful thing. So it was 1,000 years later when Edward Jenner first time introduced smallpox vaccine. 100 years later, it was Louis Pasteur who brought the rabies vaccine for us. And thereafter, all the vaccines came in the pipeline in the next couple of centuries. And the last we have is the COVID. Now, over 33 diseases are vaccine preventable. But when we think about vaccinating someone, what we should look at it would be the age of the patient, what are the comorbidities, what is the immune status of the patient, and so also the endemicity of that particular disease in that area. Now, why do adults need vaccination? It could be possible that missed out vaccination during their childhood, and it is to boost the efficacy of childhood vaccine and aid immunity for newer comorbidities. And you know that as they grow old, there's loss of immunity, so they need to get vaccinated again. And as a whole, it improves the herd immunity. Now, just look at our situation, like our ICUs, HQ, we admit so many patients who are sick with comorbidities. But how often do you tell them as a priority to get vaccination in that discharge summary, that next visit, please get vaccination done? change in the genetic setup, which happens all the time. That's why the Serum Institute, Bharat Serum and all bring out vaccines every year. Antigenic shift is a major change. That is when a pandemic happens. Now, that time what happens is the patient, the community, they don't have immunity towards that. Whereas even if drift happens, a reasonable immunity is there in the community, so it is not going to the level of pandemic. Now, about the timing, every year they bring out new strains. So I get often questions from everyone, which vaccine should we give this time? There are lots of vaccines sitting in the pharmacy. So I constantly keep in touch with Mr. Biju and ask which is the strain which has come in. So currently what we have in our pharmacy is 24-25 strain. When do the new strains come out? Usually in the month of September. So I would say across the world, when they have the proper season, it should be before the winter months. So when I was in North, the time we advised vaccination was end of October, November. Around 4 weeks before the winter sets in, they should be vaccinated. And they had the advantage of the Northern Hemisphere vaccine because by then the new set, like this September, October, we should be getting 25-26 strain. So what we have is 24-25, but the Indian guidelines say state like ours, it should be before the monsoon months. So that is when we should be getting it. Now, our hospital has taken an initiative that they have made the vaccine 50%. So what is 2,000 plus, now they are giving it for 1,000. We should take advantage of this opportunity. And sadly, I went to the injection room and I realized that the number of takers are very, very few. So it would be a good time that our staff would get vaccinated. Moving on to pneumococcal vaccine. This should be a vaccine which we should advise for all the patients with comorbidities, including diabetes, COPD, chronic kidney disease, and above the age of 60. Anyway, it is a recommended vaccine. And for healthcare professionals. Now, always this confusion between PCV and PPSV23. To make it more simple, what we have available in India is the Prevnar 13 and the Pneumo 23. Now, Pneumo 23, when we say it's a polysaccharide vaccine. So they use the polysaccharide part of the bacteria to create this vaccine. It has a reasonably good immune response. How PCV is different? It is conjugated to an additional carrier molecule which makes the immune response very robust. So the immune response with PCV is really good. However, it is covering only 13 serotypes. Studies have shown that if you give PCV 13 first and then 23, those 13 serotype would get boosted even better. And the altogether immune response is much superior than giving the polysaccharide first and then conjugated. So previously there was an understanding that PCV is for children and Pneumo 23 is for adults, but all the guidelines say, the Indian guidelines and the Western guidelines say you give PCV 13 first, followed by PPSV 23. Now, for the general population, it is 1 year later, then 5 years, and you should give one more when they cross 60 years. Now, the only difference with the immunocompromised patient, like for example, post-transplant patient, HIV patients, post-splenectomy patient, the second dose comes within 8 weeks and then 5 years later. Now, West, in US, they have PCV 20. So PCV 20, so in India, there have been they have given permission to import it now. For clinical use, it is not available freely yet. But once we have, so if you look at the ACIP guidelines, theirs is different for pneumococcal. Because once PCV 20 has come in, it's just one dose and you're good. So at any point, if someone is in the pathway of this vaccination and if PCV 20, if it's available in India, you can finish the vaccine with that PCV 20. Hepatitis B vaccination, I'm sure everyone sitting here would be vaccinated. Obviously, all the healthcare professionals. And those who are catering to high-risk population, they also should be immunized. Now, those who have, I'm sure the young adults now, all of them would have received it as part of universal immunization program in childhood. For us, I remember it came in when I was an intern. So that's when all of us went and got hepatitis B vaccination. Now, in adults, what we use is what we have in India is the recombinant hepatitis B vaccine and 20 micrograms. So we give 1 ml for them and 0.16. Now, how do we do it differently in adults? Now, for example, our medical students came in. We did their anti-HBs antibody titers. That's because we know all of them received immunization as children. So we wanted to see their immune status. And if anti-HBs antibody titers are less than 10, they need to go through it all over again. And what is the best time to check the anti-HBs antibodies? If you're vaccinating someone after that last dose at 6 months, 1 or 2 months later, that would be the ideal time. However, in the universal immunization program, that's not a practice to routinely check. Having said that, if someone has got documented anti-HBs antibodies which are good, they are protected for life, even if you see a 0 titer little later. But why does that happen? Because if they come in contact with hepatitis B, there is an anamnestic response, and the memory T cell will come into picture, and they will boost the B cell immunity. Having said that, recommendation says if someone has a needle stick injury, at that point it's 0 titer or less than 10, yes, we would give immunoglobulin and go through the 3 series, but at least we know that they are protected. Now, West again, now they have Heplisab. That they have added an adjuvant molecule called CpG to it, which makes the immune response really good. So how are their schedules different? They have only 2 doses, they don't need booster. So it's 0 and 1 month and they finish with vaccination. We don't have Heplisab yet. Now, dialysis patients. Now, they can go through either 3-dose series of double dose or 4-dose series. Now, why double dose? Because we are expecting them to not to have enough immune response. So I talked to our nephrologists. They are following the 4-dose series of 0, 1, 2, and 6 months. Ideally, we should be looking at the anti-HBs antibody titers 2 months later. So in an adult, when you do the vaccination, ideally, you should be looking at HBsAg status and anti-HBs antibodies. Why? In childhood, when they get HBsAg as an infant, majority of them would go into chronicity, right, sir? In adults, what happens is if they have acquired as adults, majority of them become seronegative at some point. So some of them would have gone through the subclinical infection and got immunity also, and they never knew about it. So if you check HBsAg, if it's positive, anyway they are infected, they are not candidates for vaccination. And if anti-HBs antibodies are present, they don't need vaccination. Now, there is a small subset of patients, I'm sure this would, either in medicine department or gastroenterologist, enterology department, they would come across this patient of just isolated anti-HBC positive. That means HBsAg negative, anti-HBs antibodies also negative, only anti-HBC positive. So this IgG, I mean. So what does that mean? That means they had a remote infection, but the immunity hasn't come in. Or immunity came in, but it waned off. So it was not a sufficient immunity they received. Or it could be an occult hepatitis B disease. So the recommendation says they need vaccination and give 1 booster. Here the cutoff is much higher. If it's less than 100, you should revaccinate them. That is what the recommendation says. Moving on to hepatitis A. Who all would need hepatitis A? Actually, anyone coming into India, hepatitis A is a recommendation. But however, people who are going into hostels or you are going to visit places where sanitation is poor, they should be taking hepatitis A vaccination. And during an epidemic, they should be getting the vaccination. So it's 2 doses, 6 months apart. But they have this combination with hepatitis B and A. So yesterday Manju had asked, some patient asked if they can be given together, and some doctors said it should not be given together. We have in fact vaccines with hepatitis A and B together. So if you give it together, the schedule we follow is that of hepatitis B. But in medicine OPD, I'm sure all my colleagues will say, they come with this long list of vaccines. They have to go abroad, visa, job, and I have to finish all this vaccination. And we always struggle, how many can you give? So here there's a provision of accelerated schedule, which you give 0, 7, 21, and to 30 days. As in 3 doses within 1 month is over, and then you give a booster 12 months later. Moving on to Tdap. Now, ideally, after they finish with pediatric vaccination, at 11 years, you have to get Tdap again. Somehow, but probably I think pediatricians catch them because they're very particular. After they're let loose. They'll never take vaccination. Only when they get a wound, they will think about it. Ideally, every 10 years, you are supposed to get Tdap or TD. Initially, you can get Tdap. Now, why AP? Acellular pertussis. In adults, if you take the traditional DPT, you have a severe reaction, so you should be taking acellular pertussis. Now, in gynae department, when I asked, earlier, I remember I received TT, but now the recommendation says Tdap in pregnancy. So they are meticulously giving their pregnant ladies, with every pregnancy, they are giving Tdap. Now, if someone, so this is when we actually come across them, would be when they come with their wound. So if it's a minor and clean wound, you give 1 dose if it hasn't crossed, if it has crossed 10 years. If it's a major wound or an unclean wound, you would give it if they have crossed 5 years. And if it is less than that, obviously, you have to give the immunoglobulins plus the vaccination. MMR. In our department, I think the last 2 years, we had so many cases of measles, which was really strange for us, and adults presenting with measles. And if you remember, one doctor had come from government as part of surveillance program, and all of us are in the WhatsApp group where we give data of every patient with fever, with rash, and we get the report in that group, and we see so many reports of measles coming every now and then. So after when I talked to Dr. Jijo, they said, actually they are supposed to get a 3rd dose, which most of them are missing. So if you ask the patients, they say they have received 2 doses, or some of them they can't remember. Ideally, as an adult, you are supposed to get 1 dose. And why this golden period of 1957? They believe that if you are born before that, you have natural immunity, and if you are born after that, the natural immunity wanes off, and you have to get it through vaccination. Now, anyone going through childbearing age, before planning pregnancy, they should get it, because during pregnancy, it is contraindicated to get MMR vaccine, or else you have to push it to postpartum period. I remember when I finished my first cesarean, when I was in the recovery, the nurse came and just gave a shot, said, this is rubella. So I remember that gynecologist was so particular that every lady should be vaccinated against rubella. So if you look at the healthcare, whether you are born before or after 1957, you're supposed to look at your immune status. That is, you look at measles, mumps, rubella, IgG. If it is present, good, you are immune, nothing to be done. If not, you are supposed to, as a healthcare professional, the advice is either 2 doses of MMR or at least 1 dose of rubella. HPV, I remember Kunyama madam presenting about HPV one day, and our gynecologists are champions in promoting HPV. Sure enough, they are seeing the other end of the spectrum where a vaccine preventable disease is coming to them, CA cervix. So we always think of CA cervix when we talk about HPV, but it's not just CA cervix, it also protects against the genital warts, anal cancer, vulval cancer, penile cancer, oropharyngeal cancer. So all these are protected with HPV. The vaccination schedule, if you, the rationale is you should give it before they have their first sexual contact. But now there's a conditional recommendation that, so the cutoff was, upper limit was 26 years. Now they are pushing it to 45 years, saying, even if they have acquired one serotype, probably the vaccination will protect against the other ones, protecting them from various cancers, because each of these cancers are associated with a particular serotype. And if they get vaccination at a very young age, before 15, only 2 doses are required. Above 15, you have to give 3 doses. Again, the confusion is in our pharmacy, we have various vaccines available. So are we supposed to give the quadrivalent or the 9-valent? The higher the valency, better, because you are covering more serotype. So the 4-valent covers the 6, 11, 16, 18. They are the main serotypes responsible for cancers. But in addition to that, this 9-valent would cover the 31, 33, 45, 52, 58. All of them would be covered in that. Varicella, again, as a child, if you have got chickenpox, natural immunity would set in, so that is fine. But sometimes, occasionally, we see there's a breakthrough infection in adulthood, but that's not the usual case. But we have seen that if they get chickenpox as an adult, it's bad scene. I remember in our unit, we had a lady who had ARDS, encephalopathy. We thought she won't make it. She barely made it. She had such a disseminated chickenpox. So as an adult, if you don't have immunity, as a healthcare person, this is a must because they are going to come in contact with varicella patient. You should get 2 doses, 4 to 8 weeks apart. But all the patients who have come to me for vaccination is post-exposure. The moment they come in contact, they're panicking and they're coming. And you should remember the moment they see the vesicles, 1 or 2 days before that, they are already exposed. So what do we do for them? Now, it depends on their immune status. For an immunocompetent patient, you can still advise vaccination. But tell them, because they are in the process of incubating that virus, so they may get an infection or they just may escape the infection. But even if they get, it may just a mild infection. So our recommendation is to give the vaccination. Now, whom do you give immunoglobulins? Those are like the ladies who are pregnant because vaccination is contraindicated for them, and those who are immunocompromised, and the babies who are born to a mother who had chickenpox just before delivery, the last 2 weeks. They should get immunoglobulins. Now, once I remember to use Zacharias as one relative came. Now, this is not there in the guideline. She is getting married the following week. And she was panicking, saying, I got exposure. Now, no girl would want to stand on their wedding day with full chickenpox. So we were so concerned, and they were saying, can we take immunoglobulins? I said, guidelines doesn't recommend that. But thankfully, the first step is always to look at the IgG. And when we checked varicella IgG, it was positive. So we just had to reassure her, saying she's already immune and nothing to worry about it. And the other problem I always notice is, they come with so much panic, they get the first dose, and they realize that they didn't get the infection, and they move on. They forget to take the second dose. If you are starting, might as well take the second dose. So you see lots of patients with just 1 dose of varicella. Complete it so that you are immune. Zoster, this is a problem with adults. Now we know that you don't get zoster from a zoster patient, but you get chickenpox from a zoster patient. Now, these patients, and the other thing we should understand is, once you get zoster, it's not that you're going to get immunity towards zoster, because it's a reactivation which is happening, which can happen again. So there is a recommendation, if someone has got zoster, you can get vaccinated after that. So I had this lady who went through post-herpetic neuralgia, a severe one. So she came to me asking for vaccination. I said, it's 11,000. She said, doesn't matter, I can't go through that pain again. So it's 2 doses, 2 to 6 months apart. So it's like 22, So for her, it's almost 22,000. She said, doesn't matter, I don't want to go through this again. But as an elderly person, you should be getting vaccine for zoster. Now, what we have is Shingrix, which is the recombinant zoster vaccine. So this is the latest one, which is what is recommended by ACIP in US also. That's why the expense is so high. Having said that, the response is pretty good. It's almost 87 to 90%, whereas the previous vaccine which we had, which is much cheaper, is just about 50%. Now, when we talk about patients with altered immunity, 2 big questions are safety versus efficacy. Now, if you give a live vaccine to someone, is it safe? Are they going to go through a breakthrough infection of that? Or if you give them, like I talked about dialysis patient, are they going to get enough immunity with that? So these are 2 questions which we need to answer as a physician before administering the vaccine. So most of the live vaccine, like MMR, varicella, the intranasal influenza vaccine, yellow fever, oral typhoid 1, BCG, smallpox, and rotavirus, most of them are contraindicated in people with who are immunosuppressed. But can you still give it to them? Yes. In leukemia, lymphoma, malignancy, if they are in remission, if they are finished with chemotherapy, 3 months later they can start. Those who have problem with B cell deficiencies, they can still get varicella. And in HIV population, we take the cutoff as CD4. Above CD4, not all the live vaccines, some of the live vaccines they can get. What about the timing? If they are on anti-rejection therapy, we should wait for at least 2 months. For immunosuppressive, at least 3 months. Anti-B cell agents, 6 months. So this would be relevant for those who are in hematology, rheumatology, even dermatologists give lots of immunosuppressants, neurologists. So the timing is important. Immunoglobulins per se is not a contraindication. They can receive whole set of live vaccine if they are receiving immunoglobulins. Now, the flip side, if someone has already received the vaccine, how long should you wait before starting immunosuppression? If it's a live vaccine, wait for 4 weeks. Non-live, maybe 2 weeks. And if they are on high-dose corticosteroids, that is more than 2 milligram per kg, or an equivalent dose of 20 milligram of prednisolone for consecutive 14 days, both ways. One is, it may not be safe for them. They can have breakthrough infection, or they won't mount immune response. What is cocooning strategy? Now, we talked about this immunocompromised patient. They can't receive the vaccination. So what we do is, you vaccinate their family members. So you sort of protect them by creating a blanket around them so that they won't bring in these diseases to them. So that is called cocooning strategy. Now, let's just briefly touch upon these 3 specific populations: HIV patients, post-stem cell transplant patient, and splenectomy patient. In HIV patient, the non-live vaccines are okay. There is not we usually recommend above the cutoff of 200 CD4, but guidelines say you can vaccinate before that. This I'm talking about non-live vaccine. However, the immune response may not be sufficient enough. So we always wait for CD4 200 before starting the vaccination. And if it's above CD4, even the live vaccine like yellow fever, MMR, and varicella can be given. However, what is on the left side of the panel, they are contraindicated at any stage. Moving on to stem cell transplant patient. Now, how are they different? Once they do the conditioning of the bone marrow, in addition to knocking off those disease cells, they are knocking off the memory T cells also. So actually, their bone marrow is going to behave like a naive bone marrow, a newborn's bone marrow. They have to go through the whole vaccination process again. So Chepsi, Dr. Akash, and your entire team, you would be doing like childhood vaccination for these adults. Now, various guidelines say various timing. By and large, it's around 6 months to 1 year later, you can start off vaccinating them. But these are the vaccines which are contraindicated anyway: BCG, the live influenza vaccine, oral typhoid vaccine, and rotavirus. We shouldn't give it to them. So our rectum has got this vaccination card, and they follow that. And they have given this details of vaccinations which are absolutely contraindicated. Now, moving on to the surgery department, we get lots of cases of splenectomy from them. Many of them are undergoing vaccination under us. We get 2 sets of patients. One is because of the traumatic splenectomy. We don't have time for vaccination. They have come in post-road traffic accident. And the advice is just undergo the surgery, and post-surgery, we can start the vaccination. Whereas if it's an elective splenectomy, like someone who's referred from hematology department, refractory ITP or something like that, there you can plan the vaccination. But you should stop vaccinating 14 days prior to surgery. That's what all recommendation says. And post-surgery, earlier they said 14, now they say within 7 days. By the time they are ready for discharge, you start vaccinating. So if you couldn't complete the vaccination, stop it before 14 days and then restart it 7 days after the surgery. Mainly we are concentrating on the capsular organism, pneumococcal, Haemophilus, and then meningococcal. In addition to that, we give influenza and influenza and Tdap. Now, when I looked at the Indian guidelines, they had in fact added MMR and chickenpox also. So I had discussed with Bello and what is the government policy, like in Trivandrum I had asked. But they also follow this similar pattern what we are doing. Having said that, MMR and chickenpox, like what I said for any adult, we should follow the same protocol. Now, some of the frequently asked questions are, one is, how many vaccines can I give in a day? Now, the answer is, you can give as many vaccines. Only very few are not compatible. For example, PCV and meningococcal should not be given together. Otherwise, even live, non-live vaccines, you can give them together. But you should look at the technicality of it. You should never mix two immunization in the same syringe and give it in the same site. It should be in different syringe and different site. But if it's a combination vaccine, for example, MMR on one side, Tdap on one side, that's fine. Because, so by then you are getting 6 vaccination. So you can give many vaccination, but I don't think technically more than 4 injections in a day is not practical. What about the timing? Now the question is, once they get the vaccination, when they can get the next vaccine? The answer is 4 weeks, especially for live vaccine. Non-live, there is little bit flexibility that you can give it earlier. And for yellow fever, all the recommendation says not before 30 days. So that is the strict cutoff. So give as many as possible on that particular day, and then leave a gap of 4 weeks before you give the next vaccine. Again, this is the problem when they have to go abroad for job, visa and all, they want to finish everything. So they say, last week I got one, can I get one more this week? So that's not possible. So finally, we come to our vaccination card. This was a dream come true. And I would like to recognize 2 people at this time, Dr. S.K. Matthew sir and Dr. Reshmi. These are 2 people in the department who came to me and told me, please make a vaccination card for our department so that we can use it. Initially, and before that, we were using a printout for post-splenectomy patients. So I was very happy with that is going on. This, as and when patient comes, we can just give the vaccine. But once I sat down to do it, I realized it was a Herculean task looking through all these guidelines and making the details. I went to pediatrics department to look at their vaccination card, but that's not going to help us in one way because they have some growth chart and they have everything laid down in months and years. That's not the case with us. So we started to start from scratch and write down each of this, looking at each vaccination. Now, if you look at ACIP, they have some vaccines which we don't have, like RSV. We don't have it in India. They have Mpox as part of the vaccine. We don't have it. So we had to make it what is relevant for our setting. So this is our vaccine. So the first page has we can put the details of the patient. The second and third page, all that I talked about, the schedule, contraindication, when to give it, timing, everything is detailed. And the last page will have where you can put the schedule. And this would be especially for the splenectomy patients. We have made another card so that they can use it. So it's my proud privilege to call up our dear GC sir, George Andy sir, to release the card. And I call upon Rashmi to hand over the card to sir. And I also would like to recognize Ronnie. I just had to give the matter to him and the columns and tables, and he made this beautiful card. And I had to go to his office once in a while. I never realized there's an office at the end of the campus. So he did it beautifully. And I would like to recognize him also. And over to you, sir.
Thank you, Jency, for that fantastic presentation. Shall we give her a standing ovation? From all of us. Please be seated. I think this is something that I must congratulate Jency for having identified a need and then worked hard on it and making a press. She's been planning this for the last 2 or 3 weeks or 3 or 3 months.
We wanted sir to be there, so that is why we postponed.
So very grateful. So today I knew that she will look beautiful, so I had to wear this somehow to try and match up on a lighter note. But thank you, Jency, for having done that. And I would encourage other faculty to do some things similar because there are so many needs for, I was thinking we should have said bringing hope and healing with the love of Christ. We should have said bringing hope, healing, and health with the love of Christ. Maybe we should have added that. But this is something that everybody is talking about, and I'm so glad that we were able to do this. Thank you, Jency. Thank you, Department of Medicine. We just congratulate you, and I hope we'll have more and more such things happening which will help the community. May I just request the four big people from the department.
I would request Dr. S.K. Matthew sir, Dr. Shahul sir, Dr. Mohan sir, and Dr. Prashant sir to go and receive the card from sir.
I will take this opportunity to introduce another brilliant star who has joined us just a few days ago. He was supposed to join on the 16th, so we were relaxed a bit, but then suddenly Professor Prashant Kumar who blazed the trail. He's from, amongst the brilliant ones from the Trivandrum Medical College, graduated, and then in Alapi Medical over the last several years, he was doing extremely well in Kottayam Medical College. Thank you, sir, for joining us. It's great to have you with us. A great teacher, a great clinician. So we have 4 stars here. So it's my privilege to release this and to give it one to each one of them. I'm sure there are one or two burning questions. I think we can take 1 or 2. We have 5 minutes more. Jency always has a question.
Thank you, ma'am. It was very, very good session. Ma'am, my question relates to, one, we have these combination vaccines. Sometimes they come for this one particular vaccine, but it is only available as a combination. So what is the solution for that? Particularly in our transplant patients, we have this group that comes, yeah. Second, some centers follow a different schedule for vaccination. If they happen to shift centers, is this a common vaccination schedule that you've given, or it could be different amongst different centers?
What I've given for
Yes.
adults?
Yes.
See, in adults, we have flexibility. So when I'm talking about general adults, there's no fixed timing, right? The timing is when they come to you. And depends on their funding, when they can get it. So they can get one now, they can get the next, not of the same thing. Like if there's a second schedule which is coming within 2 months, yes, we have to strictly follow the timing. Otherwise, if it's a new vaccine, they say after 4 months I'm going to get the next vaccine, that is fine. So we can't put a definite timing for the adults. We have to look at the flexibility. But in your case, there's a planned schedule. So what I would say is, for your 2 questions. The first question is when it comes as a combination. So this is a problem with hip vaccine, especially all over India. So for our splenectomy patients, we had to look and research. And I remember everyone in, behind the pharmacy, they have that, where is that place where it comes from? Pharmacy store, yeah. So the chippy there, when high and low looking for hip vaccination all over India, the just hip, they have stopped producing. So it comes as a pentavalent vaccine comes, of which one of them have hip as a separate vial and the other as a separate one. However, we can't give it to adults because the rest of it is like a pediatric vaccination. But if in your set of patients, if those are also part of the vaccination, you can use it. Otherwise, we tell in detail to the patient, because the cost is around 3,000-4,000, we say, but we will be using, and we show it to them also, that only this part and the other will get wasted. You remember, Grace, we had few of those patients, so we had to tell them. So across India, that is the same thing. That is the only vaccine available. So for hip, every time we spend around half an hour just for one patient, because there's a call from pharmacy, there's a call from a sister in the injection room, and the patient himself or herself would be confused about it. But that is the thing. You have to use that and discard rest of it. There's no other choice for hip. Rest of it, we have individual vaccines, no? So there shouldn't be a problem. For your second question, if they come from a different place, following a slightly different schedule. Now, this adult immunization, unlike pediatric, There's not a national one. Even the national guideline, they haven't put a timeline there. So there is, and lots of them, they'll say 6 months to 1 year. Now that institution can decide when am I going to start, like from 6 months onwards, and they make a plan for them. But if they are already following a schedule, I would say continue that. Otherwise, there will be too much confusion, because there the patient becomes important and we have to cater to the need of that particular patient. So if they are following a particular schedule and somewhere along you can finish that vaccine and put them into your schedule, you can do that. So that we have to work out on an individual basis.
Ma'am, sometimes this Tdap, DTaP, they might have got Tdap somewhere else, but in our combination it comes as the pentavalent that we have has another combination of Tdap.
So they have other things also. For adults, we are using only Tdap. I am not using that other combination which is there. It's not really needed for our set of patients. Like they have some polio along with that and one more along, hepatitis B or something along with that, I don't know.
Jency, 2 questions.
Yes, sir.
The first is, as a patient, I come here, I hear about this, I see the card. What do I then do is one question. You know, where do I go to get my vaccinations? What is the system that you've... Second is, we're reading a lot about Bill Gates and the vaccinology and how it's being misused. Is there any truth to this, or this is just rumor?
I'm not aware of the intricate details of that, sir.
So if you'll
For
tell
your
us
first
about-
question, if you come as a patient to us, yes, the place to come would be general medicine department, and I'm sure even family medicine would be able to cater to them. And now that we have a card, it's easy for us, because the last page of the card, we can discuss with them, these are the vaccines available, and then we can say, according to their age and immune status, we can decide. We can pick and choose which all are the ones, like meningococcal. Not everyone needs meningococcal. But the priority would be for influenza and pneumococcal. And one shot of Tdap. So give it to them and say, for this date, you can come for this, and then you plan out rest of it. Once you have, so the first physician in contact should write it down for them. Then it's easy. They'll just carry it across, and if second time it's with someone else, or they have moved to some other place, it's so easy, they can show the card and say, this dose is pending. Now, about how they get it in the hospital, here, because it's a vaccination, it will be dispensed only if it is recorded by a doctor in their note. So it has to go as EMR, and once it's documented, they get it from the pharmacy, and it's received from the injection room. So that is the protocol.
Sir, most of my patients, adult patients who are all diabetic or various other diseases, 95% are vaccinated against flu and pneumococcal vaccines.
Very
That's
good.
we are using in a large number and protecting this people. And I think yesterday also I discussed with one of the clinical pharmacists to do a research study whether our patient immunized as readmitted in the hospital with this infection. So there is any statistical improvement, any statistical difference in this treating this patient. That's all happening here. But entire vaccination schedule is not actually practiced in our setup because it is due to the financial constraints to the patients.
I'm free to take any other questions.
I will ask one question. So now there's a hepatitis B vaccine availability issue. So with the available small amount of vaccine we have, so there is a concept that we can give it intradermally, because only 1/5 to 1/10 of the dose is required, just like IDRV we give. So with the one vial vaccine, we can cater up to 5 to 10 patients.
See, unless we have a definitely documented recommendation, I think it may be a suboptimal response. That's what I see. What do you say, sir? Because I think you are not giving the ideal thing. In rabies, at least, they have had enough of studies and they went through it, and it has come as a national guideline. Here, it is not a national guideline
In
yet.
CKD patients are immunocompromised. So in CKD patients, they compared intramuscular hepatitis B and intradermal hepatitis B. Intradermal only 1/5 to 1/10
yeah.
dose. And what they found that the intradermal mounted more immune response than intramuscular.
So definitely it has to be taken up as a study, prove it, and then only it will come as a guideline.
Sure.
But yeah, if there is a shortage,
now
what
it's-
I would say is give them what we have, then putting them through the trauma, especially your patients, because they have high chance of getting hepatitis B because of the dialysis.
We have limited vaccines, so if we use intradermal, we can get more
In
patients.
such situation, yes, but as a guideline, it has to come from at the national level.
Ma'am, thank you for the lucid presentation. Just a few concerns. The MS office has been kind enough to give the flu vaccine to all our healthcare workers at almost half the cost. Can I have a show of hands how many have taken the vaccine? So this is a reality. As a healthcare worker, all of us should be taking it, especially this year, because the CDC has told a pandemic of flu is most likely to happen across the world this year. Last year we had very bad flu cases, so I'll strongly recommend all here to avail the services, and it can be availed to your members who are part of your family also under the same scheme. The single dose, which can be protective for all, and considering the numbers which we have, I strongly advise all to take it. That's one. Second thing, ma'am, I would also recommend you to include pre-exposure prophylaxis for rabies also.
It is there in the card.
I-
Pre-exposure we have
pre-exposure
in
don't
that.
have
Sorry.
it.
Pre-exposure, particularly we say those who have pets at home, ideally they should get pre-exposure vaccine. Veterinary doctors, those who are dealing or going to places where they may have, like on a trip where they may have risk of coming in contact with animals, yes, they are the ones who should. So difference between pre-exposure is there only 3 doses are required. It will be 0, 7 and 28. So that would
again,
be
a grey area for pediatricians. We are strongly recommending all children in Kerala should be vaccinated pre-exposure. Not
It's
a
a
recommendation.
menace in Kerala
It is
now
a
with
menace
the
in
rabies.
Kerala. Now, considering the number of children and people who have died recently with rabies, the only solution is to take a pre-exposure prophylaxis. Now, as a body, we have been pushing it as an IAP, but we have pediatricians whose children we have vaccinated. I'm planning to take for my own child because children don't tend to tell at home. We had a rabies death in our own hospital, so they don't tend to tell. So that's something which we'll advise. And hepatitis A, the recent ones have been going for transplant, is what the news we get from Aster. So hepatitis A, most of us should be getting vaccinated. I would also recommend to have a list of vaccines for healthcare workers, which can be passed on amongst us, and I'm sure the MS office will be able to give us for the healthcare workers at a discounted rate also, which will again push for more vaccination amongst
I'll
us.
ask volunteers from our department to take up that.
Thank you.
Yeah, thank you.
Thank you very much. So we will be able to finish the session by 9 o'clock. We'll be starting every quest at sharp 8 o'clock from next Thursday. And next week we have a CPC. This is a season 3, third CPC session. And this time the challenge of case solving was taken by Dr. Thomas Jacob from General Medicine. And hopefully he will be able to solve the case. And meet you all next Thursday, 8 a.m. Thank you.